6 years.
Bas.
Nice.
கரெக்டாக பங்க்சுவலாக இருக்காரு 8:30 ஸ்டார்ட்.
That's very important. What equipment is paramount in you know, right. Right. Hello, I'm Ramandeep. I'm from PGI Anterior. I've never met you, but I have heard about you. But it is very good that you realize that surgeons won't stop operating till you they start pressing. I am 50. I have told everyone by 55 I just want to be in a mentorship role. That's it. Maybe cadaveric dissections. I'm trying to prove myself. And
a very good morning and welcome back to ALAIGAL 2025. Siddhartha sir.
yes. And that is what I tell also my residents, that you need to have this time. You need to learn to stand up. Because the Indian system is such. The day you go into school, you're taught never question your teacher, don't speak up even if she is wrong. And then that can say to itself.
Sir, you are not audience. Yes, sir. Am I audible, sir? Yes, sir, you are audible, sir. Can we start? Yes, sir. Yes, sir. Good morning and welcome back to ALAIGAL 2025 Day 2. We hope you had a pleasant time yesterday and are ready for another exciting day of learning and sharing. Our first session is on anterior skull base dissection
Yes,
using
I have read it.
microdrill and microdrill by Dr.Ramandeep Virk. I invite our chairpersons, Dr. Palayapan S, ENT consultant, Kero ENT Trichy, Dr. John Victor, consultant, Energy Specialty Hospital, Absalvi, UAE, Dr. Balaji CRK, Professor and HOD, SRM Chennai, to introduce the speaker and chair the session.
This is Sanjeev Mishra sitting here as an PGI. He started with me. His wife is doing.
Hello, able to hear?
Nice meeting you, ma'am. Thank you so much for arranging this. These things would not be possible without this. Thank you. Thank you so much. Thank you so much. Thank you. Thank you so much.
Hello, able to hear?
It's a pleasure.
Yeah. Morning. This is the introduction of Dr. Ramandeep Virk. He's a professor of ENT, JIPMA, Chandigarh, PG, Chandigarh, sorry, with academic leadership, renowned for anterior skull base and endoscopic CS clinic class. And he's graduated in Dayanand Medical College, Advanced Fellowship in London. Has delivered a lot of lectures at prestigious international forums, including ARS. Active researcher with strong contributions in rhinology and skull base. Great, sir. Morning.
Hello.
Ramandeep.
Yes, am I audible or?
Sir, audible, sir. Well done.
Is the volume? Hello.
Hello. Hello.
Is the volume okay or you need?
Okay, sir. Okay, sir. Volume okay.
Good morning, everyone.
Yes.
We are going to be demonstrating a basic, surgery with the use of microdrill by Medtronic. Before we start the
So the voice is breaking.
Is it okay now or is it still lagging?
It looks okay. It's okay.
So we were thanking the Department of Anatomy, Forensic Medicine, ENT. Everyone was gotten together to arrange this dissection. The cadaver is very fresh, as you will see once I introduce my scope. So before starting, I would like to give a brief overview of the equipments we are using. Can we have the view on? So we are going to be using a Medtronic micro-defibrillator system. I will come. Basically, this is the brain, the drills, and the burrs, and the handpiece attached to it. We have a straight shot M5 handpiece on which our normal this is the normal defibrillator, what we micro-defibrillator, what we call it, on which the different kind of blades are attached. We are having the 0, the 40, the 60, the 90, the 190 degree, and the 14 degree. These are the various kind of blades that are available for sinus surgery. This can be changed. So just a brief overview for the youngsters that how does a micro-defibrillator work. It has a window which opens up, the tissue is sucked in and then it is cut. So the slower speed, the more tissue it is debulked. So since sinus surgery is because of preserving surgery, we usually work at around 3,500 to 5,000. But if I was doing an adenoid respiratory papillomatosis in which debulking is more important, I would drop the speed down to 500, 1,000. Can be done here. Then it has a forward and an oscillation mode. For micro-defibrillator mode, we use the oscillating mode, which is represented by the OSC. Forward or reverse is for the drill system when we want to have the blade or the burr spin in one direction. Then it has an irrigation. This is very important. In many systems, because of the way they have some deep, permitting to less, and your blade is continuously going to get long. So we usually start at around 25 to 30, and then we can go up according to our needs. If the floor, the blade will have the position, it will not with every little tissue that go position. The blade position. This is also very important. Many times when you are doing pediatric cases, if you introduce an open blade into the nasal cavity, the ALAIGAL abscess because of the suction pressures, the negative pressures that are formed. So you can close the blade when you introduce the micro-defibrillator into the nose. So that is just a basic overview on the handpiece which we are going up and the blade which we are going to use. I've also connected an MR8 system. So both the systems are the handpieces are connected together. It is showing me that I have a M5 handpiece currently working and I have a MR8 system on standby. So we have a multifunctional foot switch which is provided chronic equipment, and I can switch between the handpieces. So if I press this button, the MR8 drill becomes active and the M5 handpiece goes on to standby. And this we are using a high-speed drill. It can go up to 75,000 RPM. So we are back to the burner. Can you focus on the handpiece on this? So now I will show you a brief about the handpiece. This is the Medtronic M5 handpiece, and we are using a rotatable blade with this. How do we know it's rotatable? Because this part is the main part which rotates and moves the inner shaft around. So if I have to rotate the blade, we unlock it. We can have a different direction of the. Once I'm inside, it will be more clear. I'll be able to show you better. It has the irrigation port. It has a suction port. And this is the MR8 piece with a skull base attachment. I will use this as demonstration when I open up the sphenoid sinus. There are multiple ways to open the sphenoid sinus. This is that this is the only burr or the drill which can open it. Normal burrs can also open up the sphenoid sinus along with other instrumentations. Plus camera system. And we have an inbuilt light source and camera system in it. It has optical zoom, and it has a focusing ring present on the video. It is very important to know your equipment because many times we have seen the surgeon completes the surgery without even adjusting the fine focus. You go up very close to the tissue, it is very important that you refocus again. Though for majority of the surgeries you don't need to touch the focus once it's done, but when you're very up close to a structure, fine focusing needs to be adjusted. So with that, we will start our demonstration.
Ramandeep, have you able to hear?
Yes, we are.
Can you show the tip of the burr? Because you are told the terminology is closure and opening.
Yeah. So I'll show it once microderrider is inside.
Yes.
So do you see the window which is there?
Yes, sir.
I can change the dash. And do you see these little arrows which are marked? The black arrows on the blade.
Yeah.
So these are present on all microderrider blades. The reason why they are given is, say you are debulking a tissue or tumor, and normally I can see the tip and the cutting surface.
Great.
But if it is buried inside, I will not be able to see it.
Yeah.
But the arrow will tell me which direction the cutting surface.
Yes.
System which is
So when you are introducing, you have to close it, no? The serrated end. The serrated end. When you are introducing them into the nose.
Right.
Yes. So it is a zone.
It has to
Yes. Thanks to Medtronics.
for putting. And you can open the blade
Yes.
with the foot pedal. See?
Yes. Great.
So this is what I was saying, that when you are doing pediatric cases, the scale cavity is very small. When it introduce an open blade, all the tissues get sucked in. So in those
Thanks to
cases,
Olympus and Medtronics.
for both the sponsors for giving us this.
And the Department of Anatomy, the cadaver is also looking very fresh.
Very fresh.
We are going
So
to
I
see
just
the
acted
breeding.
with. Yeah. So just
Thanks to the
acted
organizing team, yeah.
could do any normal, endoscopic sinus surgery.
So you used to keep a mirror at
So,
home.
we had come in early in the morning, we had kept him there. It's just kind of, because the cadaver.
Yes.
Cadaver is. So, I'll just identify some basic. First of all, you go straight back ahead to the coana. You can see the coana
Yes.
very clearly. You
Very
can see the
clearly.
nasopharynx.
Yes.
You can see the torus tuberous,
Torus
and you can
tuberous
see
tube.
the vein, right?
Yes.
So coming back to the friendly, kind of coming into your.
So in the middle, voice is breaking.
So there are ways you can actually create more space. We start by infracturing the turbinate ileus, using full long end of the elevator shift back.
Okay.
A space that gets created.
Yeah, in
Your
fact.
whole
Okay.
lower part opens up. So you infracture and then you outfracture.
Outfracture.
But make sure you don't use the sharp surface. If you use the sharp surface, this turbinate is going to start. And since they have very vascular structure, it will go in your surgical field.
Yeah.
You use the long shaft, like maximum contact with the turbinate of the complete elevator, and then you just gently push it back.
Okay.
To open this space, so I have gently outfractured the middle turbinate.
Yes.
Make sure you don't overdo it, because at times the attachment can be at cribriform and you can have a CSF leak which you don't want. And then we put a few pieces of the
Careful.
and you can see
Yes.
the normal structures. So, the maxillary line.
Yes.
This is the
Uncinate process.
uncinate process. That is the free border of the uncinate process.
Yes.
And this free border is the one which we will target. Okay?
Yes.
Into the frontal sinus, it is very important to remove the eye in its totality.
Yeah.
Many times this upper part of the uncinate is left intact and then you are not able to get into the frontal sinus.
Close to the axilla.
Going further, yes, close to axilla. Then going further ahead, we can see the bulla.
Yes.
Very clear. When you are opening the uncinate or cutting through the uncinate, make sure you don't damage this.
Yes.
So make sure you are instruments the bulla, because if this opens, then one of your landmarks is lost. Going back, this is where the middle turbinate is going to turn.
Yes.
And this is called the basal lamina.
Basal lamina. Yes.
Okay. Another thing, if this space is not enough, you can do what is called a dry or a basal lamella relaxing incision. What we do is we gently take an elevator and we open this area up.
Yes.
This. Once you do this, your middle turbinate will fix the septum.
Yes.
So this is called a BLRI or a basal lamella relaxing incision. Make sure your elevator is not pointed to upwards or you have chances of going into the skull base.
Skull base.
Beginners, we always say that make sure you see the floor of the nasal cavity and breathe a little to it.
Yeah.
Because in that way you will be safe in all corridors. Problem happens when operating, my endoscope keeps on going up and my instruments keeps on going up, and then we enter either into the cribriform or the roof of the posterior ethmoid.
Yes.
Okay?
Yes.
Sphenoid sinus. The two sinuses which we as beginners fear are the sphenoid sinus and the frontal sinus.
Yes.
Maxillary ethmoids are okay, not too much. So we have two corridors to open the sphenoid sinus. We have the medial corridor which runs between the septum and the middle turbinate. And then we have the lateral corridor which runs through the middle meander.
Yes.
So I'll be demonstrating both corridors. And the reason that is, if I am dealing with the CSF leak in the sphenoid sinus, I don't need to go and destroying all the normal anatomy of middle meanders. If I need to take a biopsy from the sinus, I don't need to open all this. In that case, I will just go through this corridor. So for that, the easiest is, I have a small mirror, see? I gently lateralize the
This
middle
is
turbinate.
transnasal approach of spine. Yes.
Using the medial corridor.
Medial
So I
corridor.
gently
Lateralize the middle turbinate.
lateralize it.
Middle
And the
turbinate.
first structure I identify is the superior
Superior
turbinate.
turbinate. Yes.
Okay. So once I
So when you lateralize the middle turbinate, you will be seeing the superior turbinate. That is
Superior.
very important.
and that is important because the sphenoid ostia will
Ostia,
lie
yes.
behind it there.
Yeah. Just medial
That
to
will be
the.
the natural ostia.
Yeah.
Stenting it with Meroseat actually benefits us. And then the lower end of the middle turbinate gently out fracture so that I get a good space.
Yeah.
Once that is done, I push this between the superior turbinate and the septum to decongest.
Towards the sphenoid
natural
part of
ostia.
raises. That is the important area. Okay.
Correct. And I can see the superior turbinate. You see the
Yes.
superior turbinate?
Yes, sir, yes.
Superior turbinate.
So concentrate
So
is a
once
very
this-
important thing. Yeah.
So once this is done and this, Meroseat has decongested the natural ostia, you will be able to see the natural ostia of the sphenoid sinus. So that is the ostia of the sphenoid sinus. So the choana, and straight ahead, up on the choana, the superior turbinate, and the lower part of the superior turbinate, you lateralize and you open the natural of the sphenoid sinus. Is it clear?
Yes, sir. But the voice is breaking in between. Actually, he is telling it's a superior turbinate. you have to concentrate on the lower half of the superior tablet, you have to resect or you have to lateralize, then only you can see the sphenoids.
Correct.
Great.
So you can gently widen it. Okay, at this stage, we usually use a bladder and we remove this mucosa on the face of sphenoid.
Yes.
There are vessels here, which are branch of sphenopalatine. Hadad flap is going to be based. So, and for the Hadad flap, if I do a Hadad flap, I have identified the ostia. I will start making an incision which will come towards me and then start going slightly upwards. Can you see?
Yes.
I'm not making the incision, I'm just marking it out. And once you are at the midpoint of the middle turbinate, you can start to go up. You don't go up in this region because of the olfactory mucosa. You don't take out the olfactory mucosa and cause smell disorder. So from this part, I come out straight till I'm at the midpoint of the middle turbinate, and then I can go upwards. And then come forward, go down till the nasal. If I need a bigger flap, I can take part of the nasal mucosa also and make an incision here. That clear?
Yes, sir. And here, many PGs are here. So, he is talking about Hadad Bazagave, that is Hadad flap. So, from the sphenoids, you have to draw a horizontal line, but it should be below because you have to protect the olfactory nose. Then up to the middle turbinate level, you come
Midpoint here, then you
midpoint,
can go up.
then go up. And how far you will be coming
That will depend on how much you need.
depends. Okay.
The area. And it's always better to take a larger flap because if it becomes a shorter flap, you can't do anything.
Yeah.
If it's a larger flap, you can trim it later on. It doesn't matter.
Inferiorly,
And inferiorly also, depending how much you need, you can come up. You can take the mucosa from the nasal floor also.
Yes.
You can go up to wall of the nose also. These are all extended flaps.
Extended
It will all
flaps.
depend on what surgery you are doing, how much is the defect you are planning to fix.
depends on the different size.
Yes. So is that clear?
Yes, yes,
I will
very
start
clear.
with, so let me start with opening of this sphenoid, and then I will from the other for it. So like I said, we take a ablator, or if you have a cautery, or even if you have a monopolar or a bipolar, you can ablate this mucosa away. The reason for doing that is,
So can you appreciate the change of color of the olfactory mucosa and the normal mucosa in the septum?
in disease patients, no, you cannot actually. But in fresh cadavers, we will be able to show you the olfactory fibers also.
Ramandeep,
Yes, sir.
here, Badmashi Mount sir is here. Morning, sir.
Morning, sir. So I am going to start widening the sphenoid ostia. The safest place to widen is, you can widen it towards the septum. You can go downwards, right? That would be a very, very safe area where you can open it. Okay, and then once we have opened it wide enough, we will go inside and try to figure out the anatomic plan. So, do you have a smaller one? This is a large roger. Normally, size 1 works well there. I can use a drill.
Ramandeep, when you are dilating the arse downwards, in the reality there will be a bleeding, no? How will you control that bleeding?
That is why I said, sir, your first step is ablating the mucosa all around so that your field is. So it can be done with the bipolar cautery, it can be done with the monopolar on a suction, and it can be done with a publicator. These are cause a drain field.
Yes. This is very important. The lower part there will be bleeding. So you have to control with diathermy, bipolar.
Yeah. Or a bleed.
Yes.
Suction.
dilating the spinatus downwards. Because wide exposure is very important.
It's the key to any surgery, whether you're
Yeah.
doing a staph surgery, whether you're doing a functional endoscopic sinus, any kind of surgery.
Yeah.
Good approach is very important.
Yes.
And you need, so there's fresh secretions also.
The safer thing to dilate the spinatus inferiorly and medially.
Yes. Because medially we have the septum.
Septum,
That.
that's enough.
Inferiorly, if I damage something, the parents are not worried about
Yeah.
that.
In many cases, we are going to do posterior septectomy, so nothing to be
Worried about.
Yes. You are using Anterior now, that area? Or?
No, sir, I am using MR8
yes.
drill.
Drill.
High speed drill.
High speed drill, yes.
So, in normal circumstances, I would love using a coarse diamond here.
Yes.
It gives me more controlled, coarse diamond. Gives me a more controlled opening of the bone work I need to do. Actually, the Kerrison I just wanted to, show you with the drill.
Okay.
So now I'm going to
Straight away, we are able to see the spinae posterior.
Bus.
Yes. And cella area. Clivus.
That area. Now when I open it upwards, now I can see the roof of, and I still have space upwards. So I can say or take it down with a slightly upwards also. Can you reduce the irrigation to 30? In different sizes. You can now even shift over to a larger bird.
Okay.
So this mucosa in real life is going to bleed terribly.
Even here we are able to see the bleeding. It shows the cadaver is very nice. The RNC team, great anatomy department.
Live
For
color.
arranging this.
So this is very, very important for the demonstration. They are given a very nice cadaver and we are able to appreciate the bleeding. So can we give a small applause?
Round of applause.
Great. Ramandeep, be able to hear the applause? Convey the wishes to the anatomy team. Thank you.
Yes, sir.
So in cases,
That is the
so in case of where we don't have the landmark, so if you open the sphenoid sinus, we can see the level of the plane of sphenoid dilate and then proceed anteriorly.
correct. So this is what I was talking about. The sphenoid is the opening I had to create a little bit wider opening because the rhodes.
Yeah. So this is a Kerrison.
Now I'm using a Kerrison.
Yes.
But powered more controlled, opening since I'm not stripping the mucosa
Yes.
elevator. So I'm trying to maintain all the anatomy of the inferior turbinate. Otherwise, I can cut this lower part of the inferior turbinate to give a
Middle turbinate.
inferior turbinate.
Great.
So now we are in the sphenoid sinus. This is probably a deviated
Septum.
Interspinatus.
intersphenoid septum. Yeah. So if I have to take a biopsy, depending on if I have to repair the CSF leak from the root, I can keep on going upwards and creating more space. I can do a posterior septectomy. I can do a limited septectomy in this area. Okay?
Yes.
Roger. I'm going to open it a little bit more and 0 to take it away. And I'm going to trim out the part of the superior turbinate just to give me more space.
Yes.
Goes straight up, I cross check with the arrows once. I can see the cutting surface very clearly.
Yeah.
It's blocked, the blade is blocked, or the suction is not working. Check it, the
So
suction.
now he is removing the inferior portion of the superior turbinate. inferior half of the superior turbinate, so that you can easily dilate the sphenoids.
So do you see the superior turbinate?
Yes, yes, nicely seen.
So this gives me more space actually,
Yes.
and I'll be able to see that below.
Yeah.
So I can see I've opened a cell
Cell.
which is going into the sphenoid sinus.
Yes.
So this might be a cell, this might be a node cell.
Nadi.
Yeah. So we can only clarify once we have seen the scan.
Yes.
Because, so I will mark out that cell for you. This cell I have opened.
Yeah, it is.
Visible, so I open this part of the cell, I will be the optic.
No.
Because once I'm in the sphenoid, I'm not being able to see the optic nerve, which should have been visible by now.
Yes.
Okay. So is that clear? So any barrier?
Yeah.
And if I need to put it later, I will remove this glucosa, I will drill out the part of the bone,
Yes.
do a septotomy or a septectomy, and I will be able to see the natural osteum on the other side.
Yes.
Okay, so if you have time, I can demonstrate how to go to the from without being by hospital elevator. Now we are going to do a lateral approach. Again,
So this is transnasal approach. Now he is going for a transmodal.
ball approach please. Okay, again check is on the floor. Keep on checking your orientation. It happens even with the best surgeons, this orientation. Just like it happens.
Here, this is very much useful for the PGs. There are three different approaches. That is transnasal, transeptal, and transeptal. So he has finished a transnasal. Now he is going for transeptal.
So this is the unstate process.
Unstate
Unstate process has three parts. The horizontal part and intermediate.
So it is having a vertical part and the horizontal part. Yes, crazy.
So I'm just going invert
Yeah.
the lid.
So
This has to be done.
Yes.
This has to be done very
Mic
carefully.
problem.
Otherwise, it's will not
Sir.
be.
Ramandeep sir, mic close to the.
Yes, sir.
Breaking up.
ಅದು ಸ್ಟಾರ್ಟಿಂಗ್
Mic.
the lag
Close to the.
The battery.
Yeah, mic is actually okay. I think issue with the transmission.
Yeah, transmission.
So I've just inverted it out a little bit so that my backbiter can engage it.
Yes.
If it is lying flush like that, my backbiter will have trouble.
Great.
So open the backbite transfer inside this meatus.
Yes.
Don't open your back, you're going to injure the septum or the turbinate and cause bleeding.
Right.
So go inside, open it, rotate your hand clockwise, engage the uncinate, and go infero medially.
Yeah.
And you take one bite. Engage again, rotate it back, open it,
This hiatus seminaris inferior here he is doing the work.
ಹಲೋ ಹಾಂ ಗುಡ್ ಮಾರ್ನಿಂಗ್
So I've taken 2 bites, no more than 2 bites.
ಇಲ್ಲ ನಾನು ಕಾನ್ಫರೆನ್ಸ್ ಲಾಕೆ
See, yesterday they had told for the PGs you should not go
ಡಾಕ್ಟರ್ ಚಂದ್ರದೇವಿ
too much forward because you need direct that.
That's right.
அவங்ககிட்ட தான்
So once that part is removed, you separate the vertical and the horizontal part because the intermediate part is gone and this part becomes loose.
Yeah.
You see this part?
This hiatus seminaris inferior
That's the horizontal part. And
Yes.
you are in the maxillary antrum. You see?
infundibulum then maxillary.
And see the direction of the opening of the maxillary
Yes.
antrum. It is horizontal, it is not vertical.
Vertical.
So just with these 2 bites and with a 0-degree endoscope, you can actually look into it.
Yeah.
Then you go ahead removing the uncinate process. So I will use a 40-degree blade. The ideal blade here is a 14-degree, 1/4, which is called an uncinate blade. Do you have that? They have the 14-degree. I can show it to you if you want. No, they don't have it. So I'll use a 40-degree blade. 40-degree blade has a T bang.
Yes. We can see the serrated edge.
Right. So this is called a tri-cut.
Yes.
It also smooth edges. It's called the bullet. I think. What is the other writer blade you have there? So these are the tri-cut. These are aggressive feet or sharp teeth. These are the tri-cut blades. So I am removing the uncinate.
He is doing.
If you don't have a debrider, it can be done with a through cut also.
Yeah, through cut. So always the through cut forceps are better than the normal plug sleeve.
Yes,
We should
because
not
they
pull
will cut
the-
that scrap.
Yeah. All the through cut blades are good. Through cut forceps.
Now I am having little difficulty engaging this blade because I am going to engage the bola.
Bola,
So
yes.
the way to avoid that is you use a J-curate.
Yeah. Now sir is going to use the J-curate.
And pull the uncinate towards you.
Yes. See here he is using J-curate because of the upper attachment of the uncinate.
And if I try to push my debrider, it could have gone into the bola. You can have upward through cut. Up. So if I have an upturn through cut, I will show you how to cut it. If not, that is okay too.
Yeah.
It's okay, I will do it right away. So once that is there, now you can see that my blade will go safely between the bulla and the uncinate. I'm not injuring anything.
Yeah.
This step actually helps to clean your keep your field clean.
Yeah.
If you're continuously hitting bulla, it becomes horrendous, especially for a beginner.
Yeah. For the beginner, it is also
WhatsApp lo
important.
அனுப்பியிருக்கேன்
There is
பாருங்க.
an uncinate attachment, whether to the middle turbinate or to the roof of there is upper attachment. We have to see everything.
Yeah.
So preoperative CT reading is very important.
Very important. So, and you have to remove it completely, the uncinate.
Yes.
That is how the orbit wall will come into view.
Yes. Now the bulla is in the view.
Now you can see the bulla, but this part of the uncinate is still attached.
Yes.
So I can gradually pull it out with a upward leg. This part of the terminate
Supraaxillary.
attachment tends to bleed.
Yes. So how do you control that bleeding, sir?
Just keep patience. Put the piece and leave it there for some time.
Oh.
Upward.
Because that is very important area, because to do the frontal work, we have to do the work in the axilla area.
Upward flexing. No, I need the upward flexing.
Usually it bleeds.
So any questions till now?
Any questions from the PDs?
Keep your instruments close. Don't open them and never introduce a instrument like this. It will damage the septum, it will damage the lateral wall. It has to go parallel, closed and straight.
Ramandeep sir,
Yes.
question from Professor Prabhu sir. He is asking to control the bleeding, can we use the completer or bipolar cautery in the
Yes.
supraaxillary area?
Yeah, you can. I mean, there will be some stenosis, maybe not later on, but controlling the bleeding is the most important.
Yeah.
Because you have a risk of damaging the structures. I mean, synechias and other stuff you can
Yeah,
still.
So this is very, very important. We should not manage any synechia or scars in that area, because it may block the airflow tract in the frontal sinus area.
Okay, now I will shift to an angled endoscope. I will do an intact bulla technique of hope. So what is an intact bulla technique? For beginners, elevator. Thank you. So for beginners, if I open the bulla,
Yes.
I will important one. In intact bulla technique, I have the bulla posteriorly, I have the orbit laterally, I have the middle turbinate medially. There is only one place I can enter, and frontal sinus.
Yes.
But that will depend on the kind of pneumatization
Pneumatization,
frontal
yes.
sinus. So that is why it is very important to read your CT scan.
CT is very important.
And how
see
large
the
is
frontal
the
beak, frontal creases, everything.
and how large is the agar?
Yes.
Do you see side?
Very nice.
And you can see the attachment of the agar.
Yes. So the axilla should be intact, and behind the axilla we have to work to see the frontal creases, the nasate and the frontal synovial. This area is very, very important because we should not create any raw area because most operatively synovial will be there. So here he is using a bar probe like that, no?
So, do you see the cell?
Yes, sir. We are able to
That
see
is the
this.
edge of the agar.
Yeah, okay, great, sir.
And you just need to uncap this.
Yes. This is very, very important. We should not damage the mucosa here.
Yeah, that is why I'm doing it very gently.
Very gentle movement. Yes. Always frontal sinus walks should be very gentle.
So I'm gently uncapping it as I would do in a light.
Yeah.
And I am in the
Yes.
frontal sinus.
Great, sir. Great.
So identifying the agar, if you have controlled your bleeding, you can easily see the free surface, free edge of the agar.
Yes, sir.
And you just need to introduce your GQ or a ball probe and see the mucosa of the frontal sinus. I have not damaged.
Yes.
It is lying intact. If I am doing blood to injure this frontal sinus is going to still an intact Bulla technique of opening the frontal sinus. So I am going to
Sir, can you direct it and can you
Just-
show the position?
yes, I am going to show that.
Yes.
So there is only, if you go and enlarge the frontal sinus, you can already see the posterior table.
Yes. Position table. Yes.
Okay.
Very
If you-
important.
Yeah. If you go laterally, you are going to end up in the orbital area.
Orbital, yes.
And you can't go medially because you will have the skull base. So the
Skull base.
only area it can be safely enlarged is the nasal beak,
Nasal.
the frontal beak.
Frontal beak area. Can you show that area? Frontal beak area, exactly. With the bar probe or something.
Yes. So this is the front area, this one, which it's usually thick,
Yes.
okay?
Yes. So
This
there is
area,
an
this
inverse
area-
relationship between the frontal beak and the agar cell. If the agar cell is big, the frontal beak will be small. If the agar is small, the frontal beak will be big.
So now you can see the posterior
Yes.
table of the frontal sinus.
Yes.
Okay? And again, the mucosa is still more or less intact. We have not disturbed it.
Yeah.
And you can still see the cell covering. Wall. So you can still see this covering of this
Yes.
agar cell. You can get it out, right? And this is the frontal beak. Do you see this?
Yes, it is. Yeah. Very well said. Front beak.
You get specialized birds
Yeah.
with lateral leg. I have not
It is
disturbed
very, very
it. I have
important
just
frontal beak area because we have to work in that area in case of draft 3.
you have a 90-degree no, 90-degree Roger. Goes up. foot, which is like a 90. This instrument
Yes. Is it multi-jointed or? So angle carries a.
Yeah, it goes into the frontal sinus, and then you can bite out the deep area,
Yeah.
like that. Do you see that?
Yes, yes, great. Now he is dilating the frontal sinus ostia with the help of a multi-jointed. This is a type of charism.
I'm going to clean my endoscope up. I'm going to show it. So see the air white, and now you can see inside. You can see the scalloping. Is it clear?
Yes.
Endoscope is a little. See, I'm going to clean it. I'm going to.
They will
Ramandeep sir,
give a
Yes, sir.
only 45 minutes more, so please go ahead.
Okay.
Thank you.
link will
So that is the posterior table. Can you see the posterior table?
Yes, yes.
Ah, yeah.
It's very important.
Why?
Before damage.
Yeah. And the mucosa is still would be operating in a light tail. There are some secretions which are lying in the frontal sinus. So your frontal sinus and sphenoid sinus, two sinuses which beginners are usually scared of and dealt with.
Yeah.
Straightly. So when you are starting out for angle, we usually tell the beginners to start with a 0 degree and a 30 or 45 degree, never with a 70.
here 3-4 kilometers from there.
Which is
Speeds.
So for the surgical work, we should not use this 70 degree. That is only for diagnosis.
For beginners.
Yeah, for beginners. Yes.
Once you are experienced, then you can.
Can use.
Okay, so we are inside now. So to remove the bulla again, you can have multiple methods. You can do it with a J-curate. You can, yeah. So that's the basal lamella. You can introduce the J-curate between the basal lamella and the bulla, and you can pull it forward.
But it should be in the inframedial aspect.
Correct.
Yes. Great.
And the issue when you are doing bony cross with the microdeprider is going to get closed repeatedly.
Yes.
So the bulla is opening up, and you can remove the bulla
Yes.
till the orbit. Till
Yeah.
one.
Yes.
And that is the upper part of the bulla. That I can do with an angled endoscope later on. Do you see this part?
Yeah, yeah.
This is still intact. Give me a check. Give it, please.
Now you are able to see the septations in between.
Yeah.
But you have to be careful when you are using, because repeatedly you cannot use this and so to use
And
a
you have to
brittle
take-
blade mucosa touch is better than bony touch. If you are touching bone repeatedly, the life of the thing will be out. And it is costly or no.
See?
Yes.
Now the bulla is up. And
Yeah.
what do we see here? That is the basal lamella.
Basal lamella, yes.
Okay?
Yes.
Where do we enter the posterior ethmoid?
Again inframedial.
Very right.
Always
So it is-
inframedial is better.
Yeah. The lower you are, the rate is actually, because if you are very low, what is going to happen? You are going to end up in the nasal cavity.
Yes.
There is no worry with that. Okay? But if you are superiorly, you will enter into the scalpel, which, especially if you are a beginner, is going to shatter your confidence. The posterior ethmoidal cell, I'm just moving the bone, then I will take care of the mucosa. This is just mucosa that is there.
Yes.
This mucosa, you can see the opening in it, and punch it now and open it.
So when you are opening the basal lamella, you will be entering into the posterior points. Again, the posterior point area, if you are working inframedially, you can go towards the sphenoid sinus. That is transmedial approach to the sphenoid.
Yeah.
So now two approaches over, transnasal and transmedial towards the sphenoid.
You can see my sphenoid sinus.
Yeah, great sir, great.
So the posterior ethmoidal cells are single and large.
Yes.
That is very.
Ramandeep, can you hear me?
Yes, sir. We can.
One question: what speed you are using in the debrider machine?
5,000 RPM. 5,000.
5,000. Okay.
Yes, sir.
Always, or you reduce the speed also?
If I reduce, I tend to take more power. If I'm doing skull-based work, I will put it in lower speed so that more mucosa can be taken out.
Exactly.
Because skull-based work will not be a mucosa preservation surgery.
Exactly.
But if I'm doing normal punctoscopic sinus surgery, then we would like to have 5,000 RPM as the
Right.
speed.
Agreed. So this the question was from
I'm lightly pushing in my debrider blade. I can see where it is cut. I can see the arrows.
Sir, can you hear me, sir? Ramandeep, sir.
Yes, sir.
Delegates 1, anterior model and post-ethmoidal artery entry into that area. Just can you demonstrate for the benefit of both elements?
Yes, I will. Once I come up to that part, I will. I have left these tissues intact.
Okay, thank you.
I'm just doing a straight head-on work, just doing a basic, anterior and a posterior ethmoidectomy. So your orbit, laminar preparation is a very, very consistent landmark. Okay, now I'm going to move the and see what kind of cell.
Optic.
So I've uncapped that cell, which was not letting us see the optic nerve. It's probably a noddy cell. And there is the optic nerve. Do you see it?
Yes, yes, great.
So this is the classical noddy cell.
Yeah.
That is why when we were looking through the sphenoid sinus, we could see this division and that had to be over part of the noddy cell. That is why we could not see the optic nerve.
Optic nerve, yes.
Blade is blocked, please. Give me a through cut. Straight. So we can also use a through cut here to remove this mucosa and the thin bone.
Always it is better to use the through cut. Because we cannot believe, because inside the sphenoid sinus there are a lot of septations. Sometimes it may get attached to the carotid area, carotid prominence. You have to be careful. So through cut instruments are better than regular instruments.
Yes. Through cut instruments are always better than taking care of this septation.
Yes, yes.
I'm using a micro debrider, but in real life I would be a little more careful.
Yeah, yeah. For the beginner, you should not use the microdebrider inside the sphenoid. You have to be
Sphenoid
careful.
sinus.
Yes. Cold steel instruments are better.
So we have uncapped the noddy cell.
Yes.
I'm removing the last of the septation, and you can see the optic nerve.
Yeah.
So this is why this noddy cell is dangerous, because the
In case of-
scan is going to go straight through it, thinking it's the posterior endpoint.
Yeah, yeah.
And it's going, this nerve is going to get injured. And in many cases, it doesn't have a bony canal over it. It's like less
So there may be dehiscence. Cannot dehiscence.
So this is the basic work. If a junior can do this basic work, it will the anterior posterior ethmoid. You have cleared the choana. You have cleared the sphenoid sinus. You have opened the frontal sinus. Now the cells which are left are on the axial cuts. What you see, the upper ethmoidal cells. Those are the ones that usually get left by beginners. So to get to that, let's try to see the skull base. So this upper part, right bone, is the skull base.
35 minutes more.
Yes, sir. We'll finish before that.
Yes.
This is the skull base. Okay?
Yes.
So once I've identified the skull base, I know I don't need to go higher than this, and these all separations can be removed. Okay? So I can do this with a microdebrider, or I can do it with a unit. So gently you can just uncap these cells. I can also do it with a longer, I can also do it with a upward through cut.
Curve section tips also.
Yeah, whatever works for you.
We are able to see
So
the
you can-
sinus and then temperature.
Debrider upward ready. So I'm gently removing the bone. Patience is the key for a good clean field.
Yes.
But see how instruments, this does not happen with the microdebrider. And there are still some separations left on the lateral part. You can make them flush with the orbit. Again, all the sinus surgeries don't need to be a full out spare. It depends on the disease, how much disease the patient is having. So see, this is the skull base. I'm just working on removing these separations. The debrider is going to get blocked, we know it, because the bone chips tend to. And these were the upper ethmoidal cells I was telling you. And now you can see the white skull base coming into view.
Yes.
I'm still using. Still using a 0.
Yeah.
Okay. For beginners, it gives them a better orientation. Because you are looking where your instrument is going and as the instrument is going. It's not angulated. So these separations can also come off if you want to do a complete job. Okay? So once again, that is the optic nerve, this part. If I have to decompress the optic nerve, I will need
For
to
the juniors, it is very important when you are going nearby the optic nerve, don't use a covered instrument. You have to be careful. Ramandeep is a well experienced person. So for him it is like a tie.
No, so be very careful. I respect microdebriders more than anything. Because if you don't respect your instruments, they will not respect you back. JQ. So I can see the frontal sinus.
Yes.
I just have to uncap the upper ethmoidal cell. Then I will be able to see the
Yes.
below which the anterior ethmoidal. So we don't know in this case how it is running. So you see the fovea is coming to
Fovea is coming into view. Yes.
So fovea is just a depression. Behind the fovea, head of the fovea is the frontal bone.
So this is very important. Now he is defining the fovea.
And there is the anterior ethmoidal artery. You see?
Frontal sinus opening, just posterior bottom is the anterior ethmoidal artery. Yes.
That's
That is
it.
anterior ethmoidal artery. Yes.
So see how gently we uncapped it.
Yes.
No hurry, preserve the mucosa. I can use a microdebrider to get these tissues and these bone pieces out.
Yeah.
So, like yesterday, in the panel, they were discussing you injury. So, it will depend where you have injured it. Okay? If you have injured it close to the cribriform plate, it is going to retract intracranially. If you have injured it close to the orbit, blade is blocked. It is going to retract. So, that is your frontal sinus above.
Yes.
You see it?
Very nicely seen.
Possible. Then I'm going to show you the fovea. That is the phobia.
Yes.
That is one cell. We can open this up, but I've just preserved the mucosa. I'm just showing you how mucosa is preserved. And you can see multiple branches of the anterior ethmoid. Do you see that?
Yes, yes.
So it is not a single vessel most of the time. It comes out of the orbit. Okay?
Yes, sir.
Easiest way to see it on a scan is where it is closest to the medial rectus and the superior oblique. It will exit that, run in the roof of the nasal cavity, then it pierces the cribriform plate here, making it one of the weakest areas.
Again, based on this
Then it
anterior
runs-
nodal artery also, we are elevating flap because like hadad flap.
Because then it will go into the intracranial cavity, it will run in the ethmoidal salpicus, give a branch, supply the form cerebri,
Yes.
will come out of the intracranial cavity and supply the interior part of the septum. And this is the interior part of the septum which is based on the anterior ethmoidal artery.
Based on the anterior nodal artery, yes. There is another flap.
So these cells can also be taken out. You see these separations. I can take them out with a microdebrider. So microdebrider always preserves mucosa.
Yes.
And if you use it carefully, it is not a dangerous tool.
Yes, yes. But very close to the anterior nodal artery and posterior nodal artery, it should be like
Yeah,
a
that is the
touch.
anterior ethmoidal artery.
Yes.
Okay. Once we have the face of the sphenoid, this will be the region of the posterior ethmoidal artery. Now, posterior ethmoidal artery usually many times they deep in the bone,
Yes.
so you might not be able to visualize it.
Yes.
More so, the posterior ethmoidal runs deep in the bone, but mostly it runs in the artery, and we are able to identify it. So, if I work between the anterior and the posterior ethmoidal artery, that approach would be a transcribiform approach. Okay, so we can remove this bone, enter into the space.
Ramandeep sir.
Human work. Yes.
Sir, here it is a dissection. So here, Prabhu sir wants you to break the anterior nodal artery and want to show the things for the PGs.
Elevator. So number one, create space first,
Yes, yes.
and then elevate the mucosa. And you need a sharp, elevators which are slightly angulated. I am lifting the mucosa so I can use my microdebrider plate. What forces we ready? Thank you. So I've just lifted this mucosa off. I want to show you it in its totality without injuring it. It's very easy to injure it because in dissection you tend to get carried away. Since you know there will be no complications.
And this area is one of the common areas for idiopathic CSF, Anterior, because it's quite weak.
Yeah. It's thin.
Yeah.
So I have removed the mucosa, and do you see it moving?
Yes.
And it is still covered in bone here. Okay? Sure. So I'm dissecting it from the medial end now. I'm just getting the mucosa out. Suction. So do you see it now? Post. So 45-degree endoscopes work best method. So I'm just So do you see why I lifted the mucosa? Because I wanted to get totality there. So do you see its branches?
Yes.
We have a branch lower, we have a branch which is going upward,
Upwards, yeah.
wall throat.
Yeah.
So we can uncap the bone on it.
Great.
So see, it's still in
Very
the bone.
nice demonstration, sir. Yeah.
It's still in the bone. If we have a curate, we could easily have lifted the bone up. Give me that circular line. Right? Okay. Do better. The C9. Just try to get the bone up so you can get a gist of the. And again, I am trying to be as gentle as possible. I don't want to open the vessel,
Okay.
as I would not want it to be opened in real life.
Yes.
So controlled movement is very important. Majority with us, they are glued to the screen. I always tell them it is very important to see how our experienced surgeon hands are working. So this bone chips we are removing. So it's thick bone. And there is your vessel. It's thick bone. Okay. So most of it is out now.
Yes.
And I'll show you. I'll see if I can lift it out. Also, will not go under it. I need a.
We are able to appreciate because 25 minutes more. Yeah, very nice.
There you still have some blood in it. Okay? Okay. So now I can demonstrate a septectomy
Yeah.
and how we go on to the other side, straight to practical.
So now he is going to create, I think, septum window for draft procedure.
Yes, madam. Can I have a blade? They want to see after her data. I will,
Time limit is 24 minutes.
we will adhere to that.
Yes.
So like I said, it usually starts, now the sphenoid ostial fight,
Okay.
we have lost that landmark, but we still know the vessels are going there. So right?
Pinnaparallel branches are going there.
Yeah. So once I'm at the middle tablet, then I can go up.
Yeah. To protect the olfactory nose.
And then I can come forward. Okay? Then I can use the second incision. And then you join the incisions. So this normally we do it with a cautery. But the blade many times doesn't cut through very well.
This is versatile flap. This is very important flap based on the sphenoparallel artery, designed by Haddad Basakale, very close friends of draft. Sternberger.
Elevator.
Yes.
Just a moment. So make sure that the perichondrium gets lifted. Once the blood vessels will be in the perichondrium.
Mucopericardium elevated.
Otherwise, the mucosa will bleed like this.
Yes.
So you have to make sure the incision is deep enough, and then you have lifted the perichondrium.
See, the skull-based surgeries, we are creating a defect, and we should know how to repair the defect. We should assess the defect size. We can take the flap based on the sphenoparotid artery, based on the anterior pulmonary artery, and many flaps are available. Even pericranial flaps are available. So we can design. We should close the defects.
Hello. Then there is also called a reverse flap.
Reverse flap, yes.
So we have lifted it up, you see it?
Yes.
And you
Yes.
will probably see the blood vessels. Do you see these blood vessels? The things have started to come.
Yes.
Okay. So the safest way to put it into the nail holes, right? And then we usually put a piece of Nerocil on it,
Yeah.
and you can release it.
It's a spinat, we have to go laterally up to the pharyngeal canal. We have to dissect. Yes.
So I'm just doing it as I would be doing a wheel, okay? And you just cover it up with a nice large piece of Nerocil, so that when you are using powered instruments, then
Ramandeep sir, there is a request for you to show the sphenoparotid artery
okay.
foramen level.
I will. So you want me to show
Sphenoparotid foramen. Dissect laterally and show the.
elevator?
Yes, thank you. See, there is a.
So see,
Yeah.
these are all branches of the sphenopalatine, and these are the vessels on which the flap is based.
We can dissect laterally. Can go to the pharyngeal canal. Yes.
I can come from other side. I can show you the crista ethmoidalis, and then that will go into the sphenopolitan. That can also be done.
Yes.
But let me show you the septectomy first. So see this vessel right here,
Yeah.
right here. So we still lifted it. You can still open this point.
Yes. Because after then they will be doing a shoulder osteotomy in that area to remove that spinal anterior wall. Skull base work is very, very important. Wide exposure.
So you should not only know how to open the skull base, you should also know how to close it.
Yeah.
Both
After wide
sides.
exposure only you can go towards the skull base. Yeah.
So you can take a roundel. I have an upward roundel, but you can turn it right down. And then
Now he is doing a shoulder osteotomy. With the
and I can also use a drill to widen.
widen, yes.
So if I have to go to the clivus, I need this lower down.
Yes.
Okay. So now there is also
The
something
PD is
called
very important for the clivus. Clivus is an important one. Okay. It is having a 3 parts: upper, middle, lower.
something also
Yes.
called the reverse flap.
Yes.
What do you do in a reverse flap? Just like I made the incision for the hadad, I make the incision on the other side,
Yes.
and I pull out the flap from this area, the posterior one.
Yeah.
Give me knife. So the reverse flap we are using very commonly. We have published it also on our work on V3 column.
Rescue flap, no?
No, this is not a rescue flap. This is a reverse flap.
Reverse.
It gets taken from the other side.
Other sides.
So I'll tell you why.
Yes.
Normally we do this with the pottery.
Okay. because this is very important. If you are not using correctly, there will be bleeding, and the field will be messy.
Oh, sir.
Yes.
This reverse Hadar flap now is being used commonly after pituitary surgeries to cover the raw area caused by the Hadar flap.
Correct.
Because the post-op twisting is much less and the recovery is faster.
So I'm going to turn this. Can I have a better one? Second. Upward. So this covers the. So it's mistakenly called reverse head card. It's just the reverse.
Yes, yes.
So we put one suture here, and this whole raw bone gets covered. And see the tablet of the other. The brightest way.
And we can go for binaural approach.
Okay. So I'm just going to remove the leftover mucosa.
Yeah. It's a roast for the sphenoid.
The line come. I'll show you the sphenoid osteo on the other side also.
Yes.
That's the superior turbinate.
Yes.
All this we are seeing from the opposite side.
Opposite side. So binaural. So nowadays we are talking about the binaural four-handed approaches.
Yeah.
So
Can
this
you
is
see?
one.
Where is? If you have time.
Yes.
So again, the same technique is followed.
Inferior portion of the sphenoid turbinate should be removed. And after that we can see the sphenoid arch dilate. We can enter.
I'm just going to take this,
Yes.
fold it back so it doesn't come in my way.
Yes.
I'll be working from the other side. So again, decongestion, like on the other side, just press it a little bit, do some suction.
15 minutes. So,
Yeah, we'll be on time. And it was amazing how everything was started on time, even yesterday.
yes, yes.
So
Kati is
just
very
great.
sharp, sir. Professor
That
Kati
is
is very
something
sharp.
we
Yeah.
usually don't see in conferences,
Yeah.
you know.
He's staying here, I think so.
So I should be able to see the natural ostia. There it is. Can you see it?
Yes.
What is the lower limit of opening the sphenoid osteo?
We can go it down.
You can go down to the nasal, but doesn't matter.
So here it is very important. The sphenoid arch is 1.5 centimeter over the nasopharyngeal opening.
Correct.
So we are doing in some cases we are doing nasopharyngectomy for cancers. So we can go down, nothing will happen.
Correct. Okay, elevator. And can I shift to MRA? So I'm just going to get the inferior turbinate a little out of the way. Okay, gently, so I have space. That is the natural ostia. Just creating some space for my bud. Irrigation pump up. So I have a tag mark on the other side.
Yeah.
I'm just going to get rid of the mucosa. This still should become later. Might be brighter.
So the sphenoid rostrum is in the view. We have to remove that to get the wide access.
This is called the T.
T.
So right now what we have is called the owl's eye appearance.
Owl's eye appearance.
So owl because the nose and the two eyes.
Yes.
So I'm being a little radical. this side. Again, for beginners, don't insert the microdebrider into the sphenoid sinus.
Just imagine about a bird. So now it is like a beak. You have to remove the beak.
Yeah.
Also, eye already we have entered, and now we are removing the beak. It's a rostrum of the sphenoid.
These are very high speed bursts.
Yes.
And then more than you see,
This is
sphenoid is very big.
Yes.
So I would like Ajay Virk here for the work.
More than
Many people used to.
So only 12 minutes.
I'm not drinking that as
Yes.
because he that does start to do it.
Yes. Now he has removed.
More than intersphenoid septum, this rostrum you always feel the midpoint of sphenoid sinus.
I'm going to clean my endoscope once so that you can see more clearly.
Okay.
Good morning, sir. Yes, sir. I'm part of the
So
ALAIGAL
see
team,
this
sir. So how are you going to
told you
proceed
it's going back and
presentation,
it's
sir?
going to the other side. So this is here. So the right side segment is smaller. Right?
Okay, sir.
If you have a an OD on this side,
Yes.
I think you on the other side also. Now see the rostrum has become loose. You can use a we use the burr.
Yes. Yes.
Thick right. So that won't damage.
Cold steel better, sir. Just 10 minutes more. Yeah. Thank you. He's using a therapeutic.
And be gentle with your instruments. And this bone is very thick. You will ruin your instrument. That is the spheno. You see it?
Yes.
Right. So I'm going to trim the sphenoid mucosa. Shift to the right. I'm trying to demonstrate this case as I would do it in actual life.
Yes. The ball probe, can you show this in a line of
Yes.
Mosia? Divers.
So now we can see the intersphenoid septum.
Septum, yes.
It is not straight.
Now the ideal instrument is through cutting forceps.
Yeah. So we have diamond burrs for this area. We rapidly take it now when we are doing pituitary surgery. Otherwise, a thick true cut because this bone can be thick. So this is the clivus.
Yes.
We do get CSF leaks out of this area. This is the second.
Sella.
And above that is the planum.
Plane of spinatum. Tuberculum sella, please show that.
Yeah, that is the optic nerve.
Yeah.
You see
Optic
it?
nerve.
And the keratooptic
Keratoid.
recess.
Yeah.
Once I drill this and make it flush, I will be able to see it. You can see the blue hue of the
Yeah,
keratoid.
yeah.
You see it?
Cavernous.
So since this was an anorthopedic, it said optic recess would not be very clear.
Yeah.
Okay, I'm just going to move the sleeve.
Now the postgranulus is very important. Sella, he has shown the above one is called as planum and below one is called as clivus and the blue area, cavernous area, and the optic nerve above, between the optic and the carotid, that is the optical carotid recess.
So I'll just bring it down the center.
Through cutting forces because the attachment could be towards the carotid. You have to be careful. Before doing the work, we have to peel off the mucosa, sphenoid mucosa.
Mucosa. Correct. So this mucosa bleeds a lot. It takes to
Remove the entire mucosa. This is skull-based force.
forceps upward.
Yeah.
So normally we lift it off with the elevator and then try to get it out like that.
Yeah, now peel off the entire mucosa. We can see the anatomical landmarks.
So again, skull base surgery is not a preservation surgery.
Yes, yes. It's not because of preservation surgery.
Yeah, it is very different.
Yes.
Different cervix sinus. So give me a straight person. So I'm using a combination of straight and upward.
Both are through cutting.
And see how. No, this is flexible.
Next.
It's not folded. And same thing with the other side. We try to get it out in totality. See how it comes out?
Yes, yes, it's great.
And it is gently, you have to like move it backward, forward, gently, gently, and then that is the only way you can. And then you need to re-hold it. Again, I'm doing this exactly as I would have done a real surgery. And see the lowest post part is coming out.
Yeah. So
And there is no more
right.
mucosa. So mucosa now. Yeah. That is how you take out the mucosa in one piece. Because if you shred it, it is very difficult to make the bone wear all around.
6 minutes.
Do you have a larger rubber? So this work on a MR8, on a MR8 handpiece. So your question how lower we can go will depend on your access.
Yeah.
For your surgeon, for a neurosurgeon, so this won't hit here. This has to be taken out.
Yes.
Otherwise, their instruments are going to get stuck because you are going to have a suction or curate,
Yes, yes.
and then the endoscope.
All the separation should be removed.
Yeah. It should be one cavity.
Yeah, yeah.
And normally in pituitary tumor, this bone, the sella bone will be very thin because the tumor tends to grow outwards.
Yeah.
And this hump needs to, otherwise it will disturb your neurosurgeon. So we need a bigger burr
Many
here.
times neurosurgeons are very specific about the MRI, but here CT is also important to see the
It
body
is very
situations.
important because it is
CT and MRI both are important. Ramandeep sir, 5 minutes.
Yes. Roger. So I would make this flush and then I would thin out the cell. And the cell is thinned out with a diamond burr,
Yes.
not with the cutting burr.
Only diamond, yes.
Dura. And then lead going to start and then your surgeon is going to get angry at it. So you have to give him as clear a field as possible. So normally a post diamond works best for, we don't have that, but that's okay. I'm opening the cella was not on the. So a diamond burr would actually make this flush. To stop bleeding, because diamond burr stops bleeding not only by heat but also by pushing the bone first into the Hershey system. That is very important to know.
4 minutes.
Drill.
If you are showing the landmarks, it will be useful, sir.
Diva, help her. So this is a cutting burr for beginners. No, do not use this the way I am using it. Do you see your cella is exposed?
Yeah, yeah. Cella is exposed, yes.
You can still get this bone. That is the key.
Here the dura is having a double layer, industrial and periosteal layer. 2 layers of meningeal layer and industrial layer. So it is very thick But even though we have to use only the diamond bar, not the cutting bar.
Not the cutting bar. Because the cutting bar will go through.
Yeah. So since the Anterior is having double layer, we have to be careful. We have to create a U flap to see the pituitary.
So flaps again, different surgeons have different preferences.
Yes.
Some use the flaps, others don't use the
Yes,
flaps.
yes.
So basically that is, I will drill this move.
What you are straight away you are seeing is anterior pituitary, just behind that is a posterior.
So that would complete this part. Back to the nasal cavity, LF.
So the sphenoid, can you show some the anatomical landmarks?
1 second, let me get to
Okay.
Nice.
2 minutes more.
Yeah. Now you will make me do things which are normally told. But we respect that, you respect time.
Yeah.
So crista epidermis is the bony landmark
Yes.
which points us towards the sphenopalatine fold. Elevator. Is the picture focused?
Yes, sir, yes. Very well. So we have to demonstrate the sphenopalatine form, that is very, very important. And here we can do endoscopic sphenopalatine artery ligations and posterior nerve neurectomy. Against is here. Last something. Posterior nerve neurectomy. And if you are dissecting towards that, we can see the median nerves. That's the paradigm. The paradigm bone is a beautiful bone which is having a horizontal and the vertical part. The vertical
That
part.
is the sphenopalatine.
Yes, sphenopalatine. Great, sir. Great, sir. We are able to appreciate that area.
Now this will have multiple branches.
Branches, yes, sir. Beautiful, sir. And
You see there is a branch here, it's a branch here.
yes. Here, if you are putting a clamp, that is a sphenopalatine artery ligation for the fixed axis control.
And that's the sphenopalatine.
Artery, yes. Ramen.
The sphenopalatine foramen will go behind the maxillary antrum into the pterygopalatine fossa,
Yes.
which contains the sphenopalatine ganglion.
Yeah.
So that is the artery. So you can put a clip here.
Yeah.
And that is,
Great, sir.
I think, the dissection.
Great, sir.
Right? Thank you everyone.
Great, sir. We would appreciate the clap, sir. Hello, sir. Ramandeep.
Yes,
There
yes.
is a standing ovation for you. Please, request this request, please. For Ramandeep. Just to watch that, please, sir. Yes, sir. And we are thanking the anatomy department, forensic department, and the PIMS and by Karthik.
And me, and DAP, and chronic and alumnus.
Thank you. On behalf of ALAIGAL 2025, I must thank for my wholeheartedly the Department of ENT, Department of Forensic Medicine, Department of Anatomy of Pondicherry Institute of Medical Sciences for arranging the excellent cadaver lab today, and it is a real treat to watch for us. Everybody agree with that.
Yeah.
Thank you very much. Dr. Sittananda is totally organizing from there with the help of the Anatomy and Forensic Medicine Department. Thank you, and thank you very much, and thank you, Veterani. Thank you.
Thank you so much, sir, and thank you to our chairpersons as well. We will now move on to our next session, much awaited nerve oration on functional surgery in difficult pathologies of the ear and lateral studies by Dr. Kasim Dia. I invite our chairpersons, Dr. Ramakrishnan S., Director, Extra Hospital, Kalur, Dr. Ravi, retired Professor Anterior, and Dr. Karthikeyan, Professor Major, NGS Direct Oncology. Kindly take your seat on the dais.